Hello friends. Today's lecture will complete the series of discussions that I have to offer on vasculitis. Today I will be discussing the variable vessel vasculitis called Behcets. As a prerequisite, I do encourage you to watch Vasculitis: An Introduction. Again, this is part of a whole series of talks that I gave to sophomore medical students many years ago, and if you look back through my discussions, you'll see talks about things like rheumatoid arthritis and lupus. As always, there are advertisements attached to my lectures. These are done without my knowledge or consent. I do not necessarily endorse the products which are being advertised. I'm not reimbursed for this either. Today we will discuss Behcet's disease. Just as a review for those of you who have not watched Vasculitis: An Introduction, vasculitis is an inflammation of the blood vessel wall. It's associated with necrosis of the blood vessel wall with subsequent either extravasation from the vessel or peripheral thrombosis and ischemia. This could lead to tissue damage, organ death, and even death of the individual. The Chapel Hill Consensus Conference classified vasculitis based on the vessel size and the presence or the absence of an ANCA. Today we'll discuss the variable vessel vasculitis, specifically Behcet's, but I will make a nod to Cogan syndrome also. Basically, Behcet's is a condition where there's oral ulcerations frequently associated with genital ulcerations, eye involvement, central nervous system manifestations, and there can be manifestations in other organs also. This is a variable vessel vasculitis. It can involve both the arterial and the venous side of the circulation and small, medium, and large blood vessels. The inflammation that one sees in the blood vessels is primarily polymorphonuclear white blood cells. Now, as with all the conditions we treat, the etiology is not really known. However, it's felt to be that there's an environmental trigger in a genetically susceptible host. And just some data, a couple of pieces of data that support that, although there's a lot of other data, is there tends to be a greater association with the HLA transplantation antigen B51, and it tends to occur more often along the ancient Silk Road that runs from Asia back to the Mediterranean. The main manifestations of Behcet's are oral and genital ulcerations, and recurrent oral ulceration is the most common manifestation. When one does a biopsy, this is similar to and histologically to just common oral ulcers. So this is just an example of an oral ulcer. This is an ulcer of the tongue. This is an example of a genital ulcer. They can have skin involvement. And what we see here, here's a little pustular or acneiform lesion. They can have an erythema nodosum type of picture, and they can even have pyoderma gangrenosum type picture with ulceration of the skin. Other conditions that can occur include nodules, erythema multiforme, palpable purpura, which we've encountered before. Pathergy is a condition that can be induced, and what happens is if the skin is pricked with a 20-gauge needle and observed 48 hours later, one can actually see the formation of tissue damage in that site and ulceration. Typically, one does not see that with normal people. Eye involvement occurs in about 25 to 75% of the patients, and before I discuss that, I just want to do a quick review of the eye anatomy. This is a schematic of the eye. The outer coat of the eye is the sclera and the cornea, which is relatively avascular. The middle coat of the eye, or the uveal tract, is very vascular, and that's what's shown here. And then our inner part of the eye is the retina. And so when we talk about uveitis, we are talking about primarily the vascular middle coat of the eye. Now, the patients can have a very severe anterior uveitis, which is shown here, and you see a little bit of injection of the sclera. But what you see here is what's called a hypopyon, and basically there's so much inflammation in the anterior chamber that there's actually layering of white blood cells in the front of the anterior chamber. Patients can also get a posterior uveitis, and this shows a retinal vasculitis. And what we see here is exudates from the blood vessels due to a vasculitis. Other things that can include neovascularization, cataracts, glaucoma, a frosted branchiangiitis. They can sometimes have macular edema and conjunctival ulceration. And I think the bottom line of all this is if one encounters Behcets, it's very important to get an ophthalmologist involved. And I'll say that the opposite of that has occurred when I was seeing patients. I was sometimes referred patients by the ophthalmologist. The brain can be involved and they can have either parenchymal disease, and this can involve the full central nervous system from the brain to the brainstem to the spinal cord. Symptoms could sometimes include personality change, psychiatric disorders, dementia. The MRI can show lesions. I think there's some edema. The CSF may show an increased protein and white blood count. They can have non-parenchymal disease, and this is due to the vasculitis. Again, either arterial or venous vasculitis with central cerebral venous thrombosis or intracranial hypertension. They can sometimes have an acute meningeal cyst syndrome or even stroke. And again, that's due to the blood vessels to the brain. Other venous beds can be involved. They can have a venous involvement in deep venous thrombosis. Other arterial beds can be involved with hemorrhage, aneurysms, and stenosis. And symptoms of that can depend on which vascular bed is involved. For instance, if it's the coronary arteries, they can have myocardial infarction. If it's the pulmonary bed, sometimes there can be hemoptysis associated. Patients can have an arthritis, which is non-erosive, non-deforming, and primarily involves the large and the median joints. There can be GI involvement with abdominal pain, diarrhea, weight loss, bleeding from the stool. This is sometimes difficult to differentiate from inflammatory bowel disease. Indeed, you can imagine if they're having ulcerations of the intestinal tract like they do of the mouth or genital area, could look very much like an inflammatory bowel disease. Constitutional manifestations, as one would expect, given this is a systemic disease, and this includes things such as fever and malaise. Now, interestingly, compared to the other vasculitis conditions, the kidney is involved less frequently and less severe. Most recent classification criteria I could find is from the International Study Group, 1990. And basically what they looked at is a patient had recurrent oral ulceration, and that would be at least 3 episodes in 12 months. And they stated this could be observed by either the patient or the physician. So essentially, it can occur by history. And then plus two of the following. One, of course, is genital ulceration, and then either eye involvement or skin involvement, and specifically looking for erythema nodosum or papulopustular lesions or pseudofolliculitis, or a pathology test. So if they had two of the three of those, they would consider that consistent with Behcet's for studies. With respect to treatment, it depends on which part of the body is being involved. And as you can imagine, with a small, medium, and large vessel vasculitis involving either the veins or the arteries or both, there's lots of different ways it can manifest, leading to lots of different treatments, although there'll be a sort of a common theme as you'll see as we work through these. With respect to patients that have just oral and/or genital ulcers, the first treatment is just topical, triamcinolone, which is a type of corticosteroid, and oral base. If that's not sufficient, then either colchicine or apremilast are used. And of course, for refractory, then we would consider systemic corticosteroids or some other immunosuppressive drugs such as TNF-alpha inhibitors or cyclosporin or interferon alpha or thalidomide. If you recall, thalidomide was actually used as an anti-anxiety medicine back in the early 60s with limb deformities in babies, and so it's absolutely not used in women that could be pregnant. And then mycophenolate mofetil. For cutaneous lesions, likewise, either colchicine or prednisone. If they're having arthritis, again, colchicine or prednisone, and if it's refractory, again, a lot of the medicines that we would use for the oral and genital ulcers. Now, if there's ocular disease, it's very important that care be done in association with an ophthalmologist. And as I mentioned previously, my role in the care of these patients was when an ophthalmologist referred the patient to me. For anterior uveitis, typically topical corticosteroids are used with dilating drops. However, if that's not sufficient, then systemic corticosteroids. For posterior uveitis, we use systemic therapy with prednisone and azathioprine, and again for refractory disease, either TNF-alpha inhibitors, or if not sufficient, then we sort of go back to that whole milieu of immunosuppressive medicines we've talked about before, including cyclosporin, interferon, cyclophosphamide, methotrexate, mycophenolate, rituximab, toxazumab. For gastrointestinal disease, again, corticosteroids plus azathioprine plus if that doesn't work, the medicines we use for refractory other disease before. For the venous thrombosis, primarily one wants to prevent the blood clots, so that would be either corticosteroids or azathioprine. But if thrombosis occurs, then anticoagulation is added. And then for neurologic disease, again, similar group of medicines, corticosteroids with some immunosuppressive treatment. Okay, as I mentioned lastly, before I end my discussion of vasculitis, I just want to mention one other variable vasculitis, and that's Cogan syndrome. I'm just going to mention or describe what it is. It's basically a condition where there's interstitial keratitis of the eyes, so there's eye inflammation associated with a vestibular auditory dysfunction. In other words, trouble with dizziness or trouble hearing. This can be associated with a small or medium vessel vasculitis. And I'm not going to say any more about that. I will state that I don't have any experience with that during my years in practice. This now ends my discussion of vasculitis. I know it's a really broad topic. It turns out it was 7 lectures when I got it all done, trying to divide it into small enough parts, and I suspect that some of those parts were still too big. Thank you for listening. Thank you for coming to this lecture today about Behcets. This does conclude my lectures on vasculitis. If you have not already had the opportunity to do so, I'd encourage you to go back and look at other talks in rheumatology. If you are to start with my first lecture and go to the conclusion, you'll have a pretty good grounding in the field of rheumatology. Thank you very much.